Hello everyone, welcome to the Lebanese Fertility Society webinar. This evening it will be about new technology in IVF in collaboration with iGenomics. The purpose of new technologies in IVF is to improve success rate. The end point of every treatment is live birth rate, and all the technologies are dedicated to improve the success rate of this end point. Today, we will see how we can better evaluate our embryos for better chances of implantation. Even with a healthy embryo, we have to find the best timing for transfer. New technologies are here to help us have a more scientific and reproducible way for embryo selection. It will help us find the best window of implantation to avoid a desynchronization with the endometrium. Hope all these technologies will help us in our daily practice to continue to help couples to accomplish their dream of being parents. I would like to introduce my colleague and friend from Jordan, Dr. Aref Alkhaledi. Dr. Khaledi is the former president of Jordanian Fertility Society and the head of IVF and genetics in the Arab Medical Center in Amman. Dr. Aref will moderate this session and will let him introduce our eminent speakers. Thank you, Dr. Aref, and the floor is yours.
Thank you very much, Dr. George, indeed. Thanks for the Lebanese Fertility Society. It's actually a very great pleasure. I mean, this collaboration between Lebanon and Jordan. We wish you all in Lebanon the best health and best progress. And thank you very much again for you personally, for the board, and for our eminent speakers tonight. It's a very interesting and hot topic, and I know that all are interested to listen to our eminent speakers. I know that we will be starting with Dr. Rina Ghaziri. She is from the AUB. She's an associate professor in reproductive endocrinology and infertility. And today, tonight she will be talking about very interesting subjects, starting with her. It's the pre-implantation genetic testing for aneuploidy, which we call PGT-A. She will talk about the new technologies, the indication, clinical outcomes, and the results. And once she's finishing her talk, we will just give like 5 minutes for our audience. Thanks for the audience for being with us today. They can get their questions through the Q&A, and we'll give 5 minutes to answer them. If we have any more questions, we'll answer them at the end of the session. So starting with Dr. Rina, the floor is yours, Dr. Rina. Go ahead, please.
Thank you so much.
Enjoy us. Thank you.
Thank you. Well, I'm going to share my screen. Okay. I hope it's working. Well, thank you for the introduction, Dr. Khaledi. Good evening, everybody. And thank you for the Lebanese Fertility Society for hosting me tonight in this webinar. I'll be talking today about the pre-implantation genetic testing for aneuploidy, PGT-A, new technologies, indications, and clinical results. And as Dr. Abitayeh mentioned earlier, our main aim is to improve the success rate for our patients and improve implantation, as well as reach a healthy live birth rate with our couples. Now, as you all know that many in the, I would like to put, okay, for the certain. Okay. I'm sorry for this interruption. So as we all know that we have witnessed a significant increase over the past 20 years in the developed countries. We have witnessed a significant increase in the old marriages, as well as people who delayed childbearing to an advanced age. And because of that, the probability of having a baby decreased by 3 to 5% per year after 30 years of age, and even more rapidly after 40 years. And because of the delay in the childbearing age and delay in the marriage, we have witnessed an increase in the spontaneous abortions as well as a decrease in the fertility rate. Now, if we look closely at the genetic makeup of the embryos in women with an advanced maternal age, we see that there is an increase in the mitotically or in the abnormality in these embryos as a woman advances in age. And this will explain the decrease in the fertility as well as the increase in the spontaneous miscarriage. Now, is there a specific age where these problems become exponential? Definitely yes. The prevalence of aneuploidy in the human blastocyst obtained in vitro is between 30 and 85. 30 is at the age of between 30 and 31, and 85% at the age of 44 to 45%. There is an increase in the spontaneous miscarriage rate between 10% and 65%. This is between the ages of 30 and 44%. However, what is more important is that this increase becomes exponential after the age of 37 to 38. And as we all know, that the risk of aneuploidy in the human fetus in the prenatal diagnosis is between 0.2 and 3%. And I think this cut limit of 37, 38 has its importance and significance, as I will be discussing later on. Okay. So we were puzzled, and we thought, what are the best criteria to choose the best embryo, the most normal embryo to transfer for a woman's womb, and thus we can increase the chances of implantation and pregnancy in the couple. And the first thing we thought about is definitely the morphology of these embryos. Unfortunately, we discovered later that the transfer of a good morphologically looking embryo or blastocyst does not allow the selection of chromosomally normal embryos. And this has been shown in many randomized pilot studies, and one of them is the pilot study that I'm showing on my screen. Now, the second option that we thought about as embryologists and reproductive endocrinologists, other than the morphology of the embryo, is the newly introduced technology, which is the time-lapse imaging. And we thought that definitely these chromosomally abnormal embryos should have some kind of abnormal morphokinetics, which we can use to choose or to select the best embryos, transfer them, and achieve a successful pregnancy. But also, we were faced with some problems with the time-lapse. The time-lapse imaging solved one of our problems, however, it complicated other problems. And I will dissect the evidence shortly. Now, the time-lapse have shown that embryos who are chaotic embryos with multiple aneuploidies or chromosomal abnormalities have shown shorter kinetic parameters, and even they arrested earlier. However, one of the problems that we faced later is that embryos who are euploid and embryos with single trisomy might have similar kinetics. And because of that, even with the time-lapse imaging, we might transfer aneuploid embryos to the womb who carry maybe one or two abnormal or one or two trisomies. So the time-lapse was not able to solve the problem as a whole, okay? And that's why we thought about other options to choose the best embryos and thus achieve the best pregnancy, best implantation, less miscarriage, and better live birth rate. And here comes what was introduced as the pre-implantation genetic screening, and later on it became the pre-implantation genetic testing. And then the pre-implantation genetic testing was dissected into PGT-A, PGT-M, and PGT-SR. A is aneuploidy, M for monogenic abnormalities, and SR for translocations. PGT was applied on the dividing cleavage stage embryos or on the single polar body, two polar bodies, and lately the introduction of techniques where the blastocyst underwent the biopsy. So what are the indications of the pre-implantation genetic testing for aneuploidy? As I have shown earlier, the cut limit where we have an exponential increase in the miscarriage rate and a decrease in the fertility rate is at the age between 37, 38 and above. And so the indication are mainly women with an advanced female age, above the age of 35 to 38. Couples with previous pregnancy with a chromosomal abnormality, trisomies or other aneuploidies, a couple who have multiple repeated IVF failures, couples with repeated recurrent miscarriages, more than 2 miscarriages, couples where the cause of infertility is a severe male factor infertility with a count of less than 5 million sperm per ml, or good prognostic patients who are desirous of, who would like to have only single embryo transferred to the womb because they wanted to eliminate the chances of multiple pregnancy. And the main goals of the pre-implantation genetic testing for aneuploidy is, as we can conclude, is to improve the pregnancy and implantation rates, decrease the miscarriage rate and increase the risk decrease the risk of abnormal offspring, decrease multiple pregnancies if we would like to have only a single embryo transferred, decrease the time to pregnancy and the emotional burden of waiting for the pregnancy to happen, which might have a direct effect on the mental well-being of our couple, as well as improve the cost efficiency, as I'm going to dissect later on with multiple publications in my presentation. So let's start with a very small definition. The International Glossary on Infertility and Fertility Care in 2017. First, we had the term of the PGT or the PGS, but now we have the PGT, the Pre-implantation Genetic Testing, a test performed to analyze the DNA from oocyte, polar bodies, or embryos, cleavage stage, or blastocyst for HLA typing, or determining genetic abnormalities. These include PGT for aneuploidies, PGT for monogenic, single gene defects, the PGT-M, or the PGT for chromosomal structural rearrangements such as translocations and inversions, and this is what we call as the PGT-SR. So what's the evidence behind the PGT-A? Meta-analysis studies on PGT-A for 24 chromosomes, many randomized controlled studies, as well as observational studies, have shown that cycles where the PGS was applied on the cycle, there was a significant improvement in the implantation rate. This is in cycles where the PGT-A was applied as compared to no PGT-A. And this is both in randomized controlled studies as well as observational studies. The PGT-A for the 24 chromosomes also did not only improve the implantation, but also it decreased the multiple pregnancy rate as one would expect. And this was also evident in randomized controlled studies as well as cohort studies. Now, the time to pregnancy, as I said, which might be a big burden on the psychological or the mental well-being of our couple, and especially in women who are above 38 years of age, the time of pregnancy was significantly less in women where the PGT-A was applied, as well as the number of transfers or the number of IVF cycles applied on them was less when the PGT-A was used. Now, Lee also have shown that the time to get pregnant when the PGT-A was applied was less as compared to no genetic testing on the morphologically normal embryos, and this is in a cohort analysis. Now, what about the time to delivery as well as the cost effectiveness models? In a study in 2018 by Neil et al., it has shown that the time that there is a decrease in the time to pregnancy as well as an improvement in the cost effectiveness of these cycles when the PGT-A was applied. What is the age group and how many blastocysts can decrease the time to delivery as well as being more cost effective. Actually, it is in women who are above 35 years of age. This is Infertility Study in 2019, where women who are above 35 years of age having at least 3 blastocysts, and I believe everybody agrees with me that this is also very important to have at least 3 blastocysts. There is definitely better cost effectiveness for pregnancy when the PGT-A is applied on these cycles. Now, what are the different techniques that have been applied or used in the PGT-A? As we all know, in 1995, it started with the day 3 biopsies, the cleavage stage embryos biopsies, and at that point, the fish technique was applied. And with this, we didn't have the luxury of testing all the 24 chromosomes. We mainly tested less than 12 chromosomes. And then as the technology started improving, 2008, 10, 12, blastocyst biopsy was applied. We used the CGH, then the SNPs and the PCR. And then with the revolution of the NGS, next generation sequencing, 2013, 18, and 19, where validated algorithms were used, all the chromosomes, we were able to analyze them. And however, as I will discuss later, we faced one of our major drawbacks in the PGT-A, which is the mosaic embryo, what to do with this mosaic embryo and how to avoid it. Now, we know that the biopsy of the cleavage stage embryos might affect the development of this embryo, and it will affect the whole process of implantation in this embryo. And as well as this embryo, which is at the cleavage stage, has a higher chances of being mosaic embryo. And as Richard Scott has shown in a randomized and paired clinical trial, he has shown that the cleavage stage biopsy is significantly bad for the embryo, and the biopsy of the blastocyst definitely has more advantage over the cleavage stage biopsy. Now, the whole issue of mosaicism is very confusing, and we all know, if I want to put it in very simple terms, that the more mosaic is the embryo, is the higher the chances that this embryo might be abnormal. So we had to find a way where we can divide the percentage, or we can categorize the percentage of mosaicism in these embryos. And depending on this percentage, we can choose the best embryo to transfer. Definitely, we would like to transfer a non-mosaic embryo. But as I said, one of the problems that we might be facing is that we have some mosaic embryos, even if they are biopsied at the blastocyst stage. So what to do with them? And many studies have shown that, and I will show later in my presentation, that embryos with low mosaic potential might even prove to be normal embryos, and these are embryos that should not be discarded. So the PGDIS newsletter, May 2019, have discussed that the average incidence of mosaicism in most clinics is between 5 to 10% in a blastocyst biopsied embryo. Although in the previous publications, the range was between 2 to 40%. And we knew that the reason, either technical reasons or because of biological reasons, where we have an advanced female age, very bad sperms, or abnormal or non-favorable IVF conditions. I don't know if I have enough time. Okay. In summary, the mosaicism rate is 5.8%, 3.8% low mosaic degree, and 2% high mosaic degree, these in biopsied embryos. And the incidence of mosaicism was not different for 9 different diagnostic laboratories. Low and high mosaicism rates were also comparable. So analyzing the pregnancy outcome from more than 1,800 in vitro fertilization cycles with the use of the 24 chromosome single nucleotide polymorphism based pre-implantation genetic testing for aneuploidy, it has been shown that definitely the percentage of embryo transferred will be higher when the PGS or the PGT-A is applied. The clinical pregnancy is higher, and this is higher as we advance in maternal age, and the live birth is higher as also we advance in maternal age. So the successful IVF outcome can be achieved without multiple embryo transfers when the transfers are combined with the use of the SNP and the PGT-A. And as the PGT-A is applied, and this goes back to the SART criteria, to SART data in 2016, the implantation rate, miscarriage rate, implantation rate is better, miscarriage rate is less, as well as the delivery rates are even higher as the patient advances in age. Now, what about the mosaic embryos? Even if you transfer embryos with low mosaic potential, the chance of pregnancy in euploid embryo is 85%, but if you transfer the mosaic NGS embryo, the chance is still 37%, which is not, it's acceptable. As well as the ongoing implantation rate, it is in mosaic embryos, it can reach up between 37 to 50%, and this depends on how much mosaic is the embryo. The higher the mosaicism chance, the lower is the implantation potential, as you all can expect. Definitely, transferring mosaic embryo also depends on the recommendation of the geneticist or the genetic lab. There are certain mosaicism where they are not compatible with life, and it's advisable not to transfer these embryos. So the genetic lab will discuss definitely the percentage of mosaicism as well as the kind of the mosaicism that we have in this embryo, and this is very important tool in our hands to counsel our patients about their further pregnancy if they want to transfer this mosaic embryo. I will just conclude with this article where it has shown that transferring these mosaic embryos, we can still achieve a pregnancy. We can still achieve healthy babies even after the transfer, although the implantation potential is compromised. And this is a busy table where you can refer to the kind of mosaicism and the kind of chromosomal abnormalities and refer to the implantation and to the pregnancy that happened after the transfer. So, when we talk about mosaicism and PGT-A, it's very important to counsel our patients before the PGT-A. We have to tell the patients about the incidence of the mosaicism, the risk of false positive due to the biological and technical aspects, the limited experience with transfer of mosaic embryos, possible risks, decreased implantation, higher miscarriage, risk of live births, and other possibilities of just like doing another IVF cycle, which might have a better outcome in these cases. So counseling is very important. If you do the transfer of these mosaic embryos, amniocentesis is definitely recommended. And you have to counsel the couple about the high miscarriage rate, maybe also doing some kind of testing on the products of conception, as well as the karyotype of the live born. I would like to share with you the last slide where our AUB-MC experience with the PGT-A and the PGT-M. Over the past 3 years, it was a successful experience, actually. We had 33 cases, 39% were PGT-M, 6% PGT-SR translocations. Mainly they were Robisonian translocations, 55% were PGT-A for aneuploidy. These were either for advanced age, maternal age, or recurrent implantation failure, or one of them was for advanced also paternal age. 36% were biopsied on day 3, but then we moved because of the mosaicism to the biopsy on day 5. 64% were biopsied on day 5. 3 cases were not transferred yet. 7 cases, we had all abnormal embryos, so they did not have any transfer. And our pregnancy rate were almost at 70% in 23 patients who received an embryo transfer. I will conclude my presentation with this slide, and I would like to answer any questions if anybody would like to share with me his question.
Thank you very much, Dr. Ghina, for the excellent presentation. Very, very nice one. We have one question coming from Dr. Shadi Faqih. It's a comment. He's commenting a new technique of aneuploidy screening introduced by Cooper Surgical STR, the short random repeats to copy number variation used in routine PGT-A for better assessment of triploidy not detected in routine PGT-A. Do you have any comment about this, Dr. Ghina?
Can you, actually, I didn't hear the question.
I'm sorry.
I'm sorry,
it is a comment rather. It is a comment rather than a question by Dr. Shadi Faqih. It is about using the STR short random repeats, using this technology.
This technology, we're not applying it right now with the genetics lab that we are collaborating with, and I don't know if he's applying it in his lab. I would like to get his comments about that.
Okay. Any other questions? Okay, since not having any more questions in the Q&A, maybe we should proceed to our next speaker, Dr. Joseph Azoury. Dr. Joseph Azoury, our great friend, he is the founder and director of Azoury IVF Clinic in Lebanon. He is consultant, obstetrician, gynecologist, and well-experienced IVF consultant. We'll be very happy to hear from him about how to optimize the window of implantation. This is a very hot topic, the window of implantation, and we'll be very excited to hear about it from Dr. Joe. Please, the screen is yours, Dr. Joe.
Hello, I'm again very happy to be present with you in this webinar. Thank you, Dr. Aref, for your introduction, and thank you, Dr. Ghina, for your nice talk. I will be discussing today how to optimize the window of implantation. Let's start.
You can share your screen, Dr. Azoury.
Let's start first by defining the window of implantation. It is the period during which the endometrium is most receptive for embryo implantation. It is typically between days 19 to 21 in 28 days natural menstrual cycle. However, recent studies have shown that the window is shifted in up to 30% of women undergoing IVF. If the window is shifted, embryo could be transferred to a suboptimal endometrium, which can potentially lead to a reduced chance of implantation. New studies suggest that endometrial receptivity testing could increase pregnancy rates in patients with recurrent implantation failure. Endometrial receptivity testing is not a new concept. It has been done in different forms for decades. The newest and current approach, genomic, is proposed to increase pregnancy rates in repetitive implantation failure patients. Future technology shows emerging evidence that endometrial microbiome and immunology also play a key role in endometrium. There are several commercially available tests for endometrial receptivity worldwide, and they mainly use NGS or RT-PCR. The first one commercialized was the ERA test that was developed by Igenomics and that analyzed the biggest number of genes. It is available in Lebanon since 2018. In 2019, ER-PIC from Cooper Surgical became also available, and they recently published a validation paper showing 92.4% concordance with Igenomic ERA test. How do endometrial receptivity tests work? All tests follow the same concept. They are all based on the analysis of gene expression in the endometrium. The gene expressed in a and the ones expressed in a post-receptive or a preceptive endometrium. For the ER-PIC test, there is this poster that was presented in ISHRE by a Japanese group. It is a retrospective review. A total of 119 patients under 45 years old who had 2 or more failed embryo transfer and underwent personalized embryo transfer after ER-PIC testing participated in this study. It showed that 42% of the patients with recurrent implantation failure have a shifted window of implantation. After personalized embryo transfer for shifted window of implantation patient, they found that the pregnancy rate and implantation rate were similar between shifted window of implantation and receptive patient. For the ERA test of Igenomics, there are much more publications performed by the group itself, and many external publications performed by other groups. I will not go through all of them, but I will only highlight 2. The first was published in the Journal of Assisted Reproduction and Genetics in 2018 and analyzed the role of ERA test in patients who have failed haploid embryo transfer. This study showed that 22% of the patients who had a failed haploid embryo transfer presented a displaced window of implantation. And after personalized embryo transfer, implantation and ongoing pregnancy rates were higher, even though not in a statistically significant way. In the ASRM meeting in 2019, Igenomics presented the result of a multi-center randomized controlled trial they conducted, comparing personalized blastocyst transfer to frozen or fresh blastocyst transfer. This study showed a statistically significant improvement in pregnancy rate, implantation rate, and in cumulative live birth rate and cumulative pregnancy rate. Indeed, more randomized controlled trials are needed. We have been proposing ERA for our patients with repetitive implantation failure since 2018, and we have performed an in-house analysis of the efficiency of this test. I will let Dr. Jessica Azoury, my daughter, present it to you very briefly.
Hello all. Can you all hear me?
Yes, go ahead. Yes, Jesse.
So actually, I have performed an analysis, a patient and cycle autocontrol study. So what I mean by patient and cycle autocontrol study, that means that I compared the results or the reproductive outcome of patients from the same cycle that had a transfer before performing ERA and after performing ERA. So 78 patients underwent ERA tests in our clinic between May 2018 and December 2019. Only the patients who had at least a top embryo transfer from the same cycle before and after ERA were included in the study. Now, it's worthy to note that 3 patients were excluded because they had a natural pregnancy after ERA, before they even performed the second transfer. The first one was 31 years old with endometriosis and 1 previous failed transfer. The second one had a very low ovarian reserve with 2 previous failed egg donor transfers. And the third one had advanced maternal age with 1 previous failed autologous cycles. I will comment on this later on in my talk. So now, when we performed the 78 ERA tests, we've seen that more than 50% of our patients have a displaced window of implantation. And here I would like to just stress on the fact that we really perform ERA on patients with a lot of repetitive implantation failure. That means with more than 4 or 5 failed previous IVF cycles. Now, in my study where I compared the patients in the same cycle before and after ERA, I had the same number of embryos transferred before and after it, and the average of number of embryos that we transfer each time is around 2 and is not statistically significant. Now, the results we have show an 18.2 increase in clinical pregnancy rate after ERA. And this percentage is really very high. So it was like surprisingly high. So we had to think that, is this increase really due to the ERA itself, or it is due to the fact that we're putting 2 more additional embryos, or is it due to the fact that we're performing endometrial injury per se? And it has been shown that endometrial injury or scratching also has a positive effect on implantation rate and pregnancy rate. So in order to know if the increase is due to the transfer of 2 additions of embryos, we refer to the paper of Garrido et al. That did a very big analysis on 51,000 transfer, and that showed that the transfer of an additional embryo increases cumulative live birth rate by approximately 2 to 3.4%. So the 18% that we were seeing was not due to the additional 2 embryos that were transferred. So we wanted to see whether it was due to the endometrial injury per se or to the ERA. So in order to answer this question, we divided the included patients into 2 groups. In the first group, we included the patients that had more than 12-hour difference timing at which embryo transfer was performed before and after ERA. So this group is the patients where really the timing of the transfer was modified after having ERA report. And in the second group, we included the patients that had less than 12 hours difference between the timing at which embryo transfer was performed before and after ERA. So it's like it was performed at the same timing before and after ERA in the second group. Now, the patient characteristics were really similar in both groups when it came to age, smoking habits, and the average number of transferred embryos. And surprisingly, what we see is that there is no statistically significant difference between the 2 groups, and we had more ongoing pregnancies, or a high percentage of ongoing pregnancies in the group where there was no difference in the timing before and after ERA. So our results suggest that there is no difference on ongoing pregnancy between the 2 groups. Hence, the efficiency of the ERA seems to be mainly related to the endometrial injury itself rather than the window of implantation timing change. Based on these results and taking into account the economical situation our country is going through lately, we are favoring endometrial scratching on endometrial receptivity testing. However, we are still proposing ERA and ER-peak for the patients who ask about them. Now, there is one point I would like to highlight at the end. it's that scratching and endometrial biopsy lead to an increase in endometrial immunity. And scratching is only recommended after 2 failed transfers. Okay, so is it safe? Will it be safe to propose personalized embryo transfer to all patients when it will be more affordable? Or will it be only recommended for patients with repetitive implantation failure? So, of course, much more randomized controlled trials are needed to answer to these questions. And thank you for your attention.
Thank you very much, Jessica, for you and for Dr. Azoury for the presentation. It will ignite good discussion tonight, I believe. I'm not sure if we have questions. We'll give like, just check out. So I'm not having questions really, maybe there are comments. I would suggest going ahead with Dr. Luis Navarro, who's our third speaker, who will enlighten us tonight with his talk about the embrace the new era generation of PGT-A. So the screen is yours. Go ahead, shoot.
Okay, thanks a lot. I'm gonna start by sharing my screen with you all. Okay. Okay.
Jessica, don't go away. We will have a lot of questions for you.
So I'm a molecular biology specialist here in Spain in genomics, and what I'm gonna show you today is our experience until now in the development of a non-invasive approach for PGT-A, for pre-implantation genetic testing for aneuploidies. Nowadays, the most common strategy for PGT-A is the analysis of a trophectoderm biopsy, let's say between 5 to 8 trophectoderm cells, and analyze it by next generation sequencing. This strategy implies an invasive act to the embryo, and what we have been trying to do for the last years is to have another option, a totally non-invasive alternative, where we analyze the sperm culture media where the embryo is developing, and also by the analysis by next generation sequencing, try to find if this embryo is euploid or aneuploid. By the analysis of the sperm culture media, what we are doing is analyzing the cell-free DNA that is released by the embryo during its development. Different studies have observed that as the embryo is growing and the number of cells increase, the amount of DNA present in the media increases. And that's our objective, trying to analyze this embryo that it's still unknown why the embryo is releasing this cell-free DNA. But we know that there is DNA in the culture drop where the embryo is in culture. So there have been different groups working in this topic. This is a brief summary of some of the results that some of them have presented until now. And the main goal of this slide is to show you that different groups have tried different approaches. They are called non-invasive, although all of them imply assisted hatching, vitrification of the embryo, or even the ones on the orange square. Those ones were collapsing the embryo and mixing the blastocoelic fluid with the media. So all of them somehow are not as invasive as the trophectoderm biopsy, but they are somehow invasive. And you can see that the concordance between the result of the analysis of the media with the analysis of the biopsy, trophectoderm biopsy, are quite different. As all the studies, even ours, have the same approach, and it's comparing the result of the media with the result of the biopsy. Because nowadays, for PGT-A, the result of the biopsy is the gold standard. So we need to be sure about how the media is working compared with this trophectoderm biopsy. Until now, we have already published 3 papers. The first one was in 2018, and actually this one didn't work properly. So it wasn't good. The results weren't very good, but we learned a lot about it. So we learned what not to do. The concordance in this case was not very high because we observed that there was plenty of maternal cell contamination with cells from the cumulus. But at least we got some knowledge about the DNA, the cell-free DNA present in the media, and we use all this knowledge for the subsequent analysis. So we published two other studies, one pilot study in 2019 and the interim analysis of a multi-center study this year by the end of May. And I'm going to briefly explain what we found in those two studies. First, in the study published in 2019, we had three main goals. One of them was to change our lab protocol by, with all the knowledge we had obtained by the previous study. And then we wanted to apply to find out how this was having a consequence in the concordance rate between the result in the media and the trophectoderm biopsy, and how this was translated with the clinical outcome. So for the first goal of this pilot study, here you can see the pilot study was conducted in collaboration with a clinic in Rome, with Genera, and we analyzed 115 blastocysts, and for them we compared the trophectoderm biopsy and the media. After all we have learned, and also reading all the studies that have been already published, we decided that we had to focus on day 4. It was very important to change the media on day 4 in the morning, and then analyze the drop of culture media from day 4 up till day 5 or day 6, and check how was the concordance in those cases. We also realized after the previous study that it was very important to get rid of cumulus cells. So that's why we were very careful with the washes to trying to minimize the maternal DNA contamination. With all those changes in the protocol in the embryology lab, we found those results, and we observed that the concordance between the result of the media and the trophectoderm biopsy was lower when the embryo was in contact, was in culture only from this new drop from day 4 till day 5, and it was a lot higher when we maintained the embryo from day 4 till day 6 in this new drop of culture media. The numbers are not very high, so it was 27 in day 5, 81 on day 6, but it was clear that it was the amount of DNA and the integrity of DNA was better when the embryos were staying longer in the culture drop. And as you can see, the informativity, we could amplify all the DNA for all the embryos, for all the DNA on day 6, and that wasn't the case for day 5. In addition to this, regarding the clinical outcome, we realized all the transfers, the clinic in Rome was transferring the embryos following their standard routine, taking into account the result of the trophectoderm biopsy, of course. All of them were euploid, but not all the related media were euploid. And we observed that there were some parameters of the clinical outcome that were different in the cases where the media was showing a different result than the trophectoderm biopsy. So if the biopsy was euploid, but the media was giving an aneuploid result, we observed, although again, the numbers are not very high, but there was a higher miscarriage rate, and more importantly, the ongoing implantation rate was quite low in those cases. So that was something to take into account, and we decided, okay, we published this, but we know the numbers weren't so high, so we are still working on that. After this, all those three aspects that I have just mentioned, we decided to make a bigger study, not just with Genera, with this clinic in Rome, and we included in the study other 7 clinics. And after more than 1 year analyzing embryos and trophectoderm biopsies and sperm culture media, as you can see here, more than 1,300 pairs of samples in those 8 centers all over the world. We the study pretends to analyze more samples, but we decided to show, because we thought it was important, how were the results in this interim analysis with more than 30% of the samples already analyzed. So again, the most important objective was to compare how were the results between the trophectoderm biopsy and the media. In those 8 centers, you can see all of them, sorry, because I forgot to say, all the centers were culturing the embryos from day 4 till day 6 in this new drop of media. We asked them to be very careful with the washes, trying not to contaminate the sample anyway with maternal cell contamination or with the embryologist per se. So on day 4 in the morning, they were changing to this new drop and they were collecting the media on day 6. As you can see here, the concordance, the overall concordance was around 80%. The range was quite high, between 72 and 86. We are, this is the average after 1,300 pairs of embryos compared. We know that with this experience, and we are still working on this, if the centers are paying attention to our recommendations, the concordance can be even higher than 90%. But they need to be very careful and they need to follow the protocol as we mentioned. Again, as you can see, for the sensitivity and the specificity, the results were again around 80%. So we were more or less happy with the result. And there were a few details that we want to share with you. We observed a linear trend regarding the concordance. It seems that as the age of the patient, female patient, increases, the concordance between both samples, the trophectoderm biopsy and the media, is higher. And regarding, we were only paying, stressing the point to the laboratories, to the different clinics, about the protocol, our protocol. Our protocol was implying washes, how to work in the lab, cleaning surface, but not about which media to use or which incubator. So each clinic was using their own incubator, and we observed, as you can see here, that the differences between the culture media used, so there were no differences. So the culture media used in the for culturing the embryo is not affecting the integrity and quantity of DNA, and that's good because we are not making the clinics to do kind of important changes in their usual routine. And again, the same conclusion for the incubator model. All of them were conventional, but as you can see, the concordance rates, the difference between the concordance rates weren't statistically significant. In one of the clinics in US, in Boston, we were able to analyze for the same embryo, not just the media and the trophectoderm biopsy, but also the inner cell mass. And that was very important for us because, as I previously explained, we know that there is DNA in the media, but we don't know which is the origin. So as you can see here, the comparison between all those 3 types of samples, although the number of those cases wasn't very high, so we are still recruiting more embryos to continue with this sub-analysis. As you can see, that the concordances between those 3 types of samples are not so different. So our idea is that the DNA that is present in the culture media belongs to both parts of the embryo. We are not very sure if it's more from the trophectoderm or more from the inner cell mass, but we have observed that both of them are secreting DNA in an unknown mechanism for the moment. After all these results, we decided that we wanted to give the option to the patient. So we are offering now till from the summer, we are offering this as a test, and we have called it Embrace, where it means embryo analysis of the culture environment. And what we are offering to the patients is it's important to stress the point that we are offering it as a prioritization system. It's a new biomarker. We don't want, for the moment, we don't want to consider it as something that is going to replace PGT-A by the trophectoderm biopsy. Not at the moment. We still need to finish our studies and have more conclusions. But we know that it can be very helpful to all the patients. So that's why it can be considered as a biomarker. And it's important to stress some details, so some aspects of this Embrace test that we are offering. As previously mentioned, we are only offering it to embryos that have been in culture up to day 6. because we have observed that at least until now, the integrity and quantity of the DNA is not good enough if we only have the embryo up till day 5. So for the moment, it's only available for embryos in culture until day 6. Day 7 is just for some cases in some clinics that they want to have a delayed culture, but mainly for day 6. Day 7 is going to be even better because there is going to be even more DNA, but it's not necessary. It's offered only for the first cycles, and clinics can use ICSI or IVF. That's not a problem because we have observed that there is no contamination with sperm. And for the moment, we cannot offer to patients with translocation or monogenic diseases. Not yet. We are working on that, but at the moment, we cannot offer it to those patients. And what we are asking the clinics that want to start working with us is to do a dry run, a validation. And that's because although the changes in the laboratory, in the embryologist laboratory, are not so important or so difficult, but those tips, we understand that the clinics need to feel comfortable with those few changes. So we need to explain them how those tips and work with them and how to implement in their labs. And we just want them to play and to be sure that they are happy with that and that they are gonna do it properly. Because mainly the main problems that we can have are contamination. And so we need to be very careful on that. That's why we need to work with them. So, but as I said, it's just because we want everybody to feel comfortable and not think that they are risking any embryos. For this dry run, we are mainly asking the clinics to send us 10 pairs of samples. So for the same embryo, they will have the culture media and the trophectotic biopsy. We will compare the results, and if in at least 8 of those 10 cases, the concordance is okay, we will consider that the protocol has been followed properly and they can start sending clinical samples. In the interim analysis, we have been working mainly with conventional incubators, but we have the option to offer it to clinics that are working with time lapse. It's also feasible. So in case any clinic wants to start working with us, we will contact them and we will see how are their circumstances, and we will adapt because we know it can work just following those specific tips. As previously mentioned, this is going to be offered as a prioritization system. So for each culture media, depending on the result observed, the diagnosis, we will give it a Aneuploidy score. So it's going to be based on the probability to correspond to a aneuploid blastocyst. So all the embryos are going to be classified, and the one with the highest Aneuploidy score is going to be considered the first one to be transferred. Depending on the aneuploidies observed, aneuploidies or euploidy of the media, each media is going to have a different score. We are going to rank them, and we are going to give to the clinic a report with the result. There are going to be 3 different types of reports. All of them have the possibility to show the presence of chromosome Y, and the different types of reports, what they do is to give different information. The basic report is only giving back to the patient the priority of each media. Special findings report, we are giving back, so we are saying which is the priority for all of the media, but also if we have observed any aneuploidy on the sexual chromosomes or chromosome 13, 18, or 21, we are also reporting that. And in the extended report, we are showing all the aneuploidies for all the chromosomes, all the 24 chromosomes. And we know that we still need more information. So we have developed all this system of prioritization. We use all the information of the interim analysis. We develop an algorithm, but we need to still have more information for the concordance between biopsies and media. And at the same time, we know that the clinical outcome is going to be very important. So we need to let's say, feed our algorithm with real deliveries, the real healthy babies born. And so that's why we are still waiting for the results of the clinics to be shared with us. And we have also started another study that is a randomized control study with 15 clinics all over the world. And in this case, we are going to culture all the embryos as previously mentioned, following this protocol. And then we are going to have two groups. In one of them, the transfer is going to be made only based on the morphology, but in the other is going to be made based on the result of the media. And what we want to check is that if the result of the media, if the media can improve the ongoing pregnancy rate. So we will also use this to improve our results. Those are the 15 clinics all over the world that are participating in this study. And just finally, I would like to show you which are the colleagues that are working with me in all this field. So we have our scientific director, that is Carlos Simon, our colleagues with the clinic from the clinical studies that are helping us with all the paperwork, with all the clinics, and then my supervisor, Carmen Rubio, as well as my colleagues, Carmen and Lucia. We are all the ones working in this amazing topic. And that's it. Now I'm open to solve all your doubts and questions. And thanks a lot for your attention.
Thank you very much for the very interesting technology, Dr. Navarro. I think it will be very exciting, and I think we may have a good number of questions related to this technology and how we can apply it. So I will start with one question coming from Dr. Khaldoun Khamaise, who's the current president of the Jordanian Society for Fertility and Genetics in Jordan. He's mentioning that he has a patient who's 41 years old, undergoing her first IVF cycle with potential 4 oocytes. And the patient, she's asking about PGT-A. How would you counsel her? Maybe the question would go to Dr. Rina, if you have any comments.
Marhaba, Dr. Khaldoun, how are you? Hope all is well. Anyway, now, as I have shown earlier, that the cost effectiveness and the time to pregnancy is highest in patients who are at the 38 years of age cut limit and more than 3 blastocysts. So I would believe the best time to counsel this patient is to wait and see whether her embryos will reach the blastocyst. As he said that she's 42-year-old, I guess, with 4 oocytes. So I don't know how many of these oocytes will be able to reach the blastocyst stage. And I think at that point, this is when I will be able to counsel the couple about the PGT-A or not, whether to proceed with it or not. So I think always the secret behind behind everything is counseling, where you sit down with the patient and you tell her about the chances of pregnancy, what are the chances that this embryo is a euploid or aneuploid. But I think the most important step at this point is just to wait and see whether the embryos reach the blastocyst stage or not.
Thank you, Dr. Rina. Any other comments from our presenters or the audience?
Dr. Joseph, شو رأيك?
Can you unmute Dr.
I'm waiting for blastocyst. It's better to wait than more than 4 eggs. How many blastocysts we can have? Normally you can have 1 or 2 maximum. To do PGA, it's minimum. إذا نعمل cumulative ممكن يعمل another cycle. And
you mean embryo pooling? I think this is definitely an option for them, where you can do embryo pooling and it becomes cost effective.
I agree with you.
More than 3 or 5 for blastocysts, we can do the PGT. It's better, not for 1 or 2 blastocysts.
So any other comments? Dr. Navarro, your experience with iGenomics and at EV, what do you think about those producing low number of eggs, low number of embryos? I mean, how much effective would be applying PGT-A to maximize their chances of pregnancy?
I think I quite agree with my colleagues, because first of all, we need to see how many of those eggs finally are blastocysts. And then, I mean, if the probabilities of having an aneuploid blastocyst at 41 years of age are quite high, but if there is at least one, if she at least has 1 or 2, we can think about this, depending on if she wants to go ahead anyway, we are gonna need to let her implant it. If not, I mean, it's quite a good idea to do a PGT-A because for the age it's gonna be quite sure Aneuploidy. But I totally agree with them. We need to wait until she reaches that point.
The
Thank
idea,
you,
if I can allow myself a small opinion, actually. So we all know that the majority of
Jessie, go ahead, please.
Yes. So the majority of aneuploid embryos will not implant anyways, and PGT-A is still much more expensive than transfer itself. So we can just like advise the patient, tell her about the risk of aneuploidy, but the majority of them choose to go for the transfer instead of doing PGT-A when they have a low number of embryos. I agree that when there's a big number of embryos, definitely it's better to go for genetic testing. But when there's a low number of embryos and we reach 1 or 2 blastocysts, it's much more effective just to do the transfer because aneuploid embryos will not implant anyway.
Thank you very much, Jessie. We have another question by Dr. Mohja Falah. She's asking, can PGT-A diagnose de novo mutation? Dr. Navarro.
No, if it's a de novo, because PGT-A is looking for the number of chromosomes mainly. I mean, it can go up to, in our case, up to deletions of 6, 10 megabases. For de novo mutations, we need to go for PGT-M.
Depends on the size. So very small size gene, it has to be by the PGT-M where you have the exact primer for this mutation.
And you have
so it goes by the size.
Yeah.
And you have to know the precise mutation itself.
Exactly.
So it's not any mutation. Yeah. We have another question, I believe, coming from, again, from Dr. Kawakib Abdullah. Hello. She has a patient, 31 years old, with 7 recurrent complete molar pregnancies. Is there any hope to do IVF? Very good question, because genetics is involved in molar pregnancy. Who can help in answering this question?
The problem is with these patients, most probably you will have lots of mosaic, maybe abnormal embryos. And the question is whether to return them or not. And especially that this patient had previous molar pregnancies. And this will put her at high risk of another molar pregnancy. And if she gets another molar pregnancy, you never know if this pregnancy might be it is aneuploidy now or not, and that's why it's very dangerous. So the question, again, it is about counseling these patients. I don't know if the PGT-A will be of much of help, especially if we have a high number of embryos with moderate to severe mosaicism in these cases. What do you think, Dr. Azoury?
And I think she must wait because يمكن تكون repeated يمكن يكون ميتاستاز يمكن تكون إنه she must wait.
Exactly. You might increase her risk of aneuplasm.
يمكن مش تكون نيو مول يعني تكون يمكن مول ancien وهلا she has a new repetitive. Donc it's better to wait not to be pregnant now and not to do ولا IVF ولا I pregnancy. But I think it's better to.
Going back to Dr. Khaled, these patients with such high number of recurrent molar pregnancies, I think we should fish for some kind of a genetic mutation in these patients. And it has been repeated in families. It has been reported in families that these patients might be at high risk of some kind of genetic mutations. I don't have the exact mutation now in mind because we reported a family a few years ago with Dr. Saoud. But I cannot say that PGT-A will be able to help these patients, honestly.
What do you think about doing a karyotype to the patient? Or
karyotype is not enough. Karyotype on these patients are not enough. Usually these patients they come to you exhausted. They did all the tests. Karyotype is not enough. They will have a normal karyotype. most probably it's just a subtle kind of genetic mutation that will increase her risk of a molar pregnancy.
Okay.
Thank you. Now we know with the partial mole, it goes with triploidies. That's it's an aneuploidy, but with complete moles, I mean, it's 46 chromosomes. But I believe you're right, doctor. I had a discussion earlier with them. There is a kind of mutation, I can't recall the mutation, that can keep producing complete moles. It's difficult one because I had a similar case and I couldn't do anything for the patient really. I couldn't really identify the gene involved in producing this case itself. Anyway, very interesting question. Any comments?
Farah is suggesting, Farah from Genomics is suggesting whole exome sequencing. To be honest, I haven't I didn't come across a paper where it has been done to patients with recurrent molars, but it would be interesting to do this test on the couple that Doctora mentioned.
Thank you very much. Any more questions or comments by our colleagues? Jesse, your comment on the ERA test, and you had a small number of patients and drawing conclusion that the mechanical scratching was the real reason behind the pregnancies. Can we really draw that much conclusion, or maybe we need more patients?
No, actually, Dr. Aref, the scratching is already established. There's a Cochrane review about it that shows that scratching increases pregnancy rate and is recommended like after two drawing this conclusion. I was just seeing positive effect of the ERA test, and I wanted to see if this difference was due to the shift in the timing or to the scratching itself. I'm not drawing a conclusion about the scratching. I know I don't have the right to do that, but there's a Cochrane review about it.
You have all the right, my dear. It's only we are talking science. We're not commercial, so the floor is always open for the evidence. We're looking for evidence-based medicine.
But I'm sure that randomized, because the randomized controlled trial that Dr. Simon did at the end of the day, it showed some kind of improvement, and it was statistically significant. And it was the only randomized controlled trial conducted. Okay, so I think that there is an improvement for the ERA, and I'm with it, and we're still performing it, because at the end of the day, really, patients with repetitive IVF failure, they need this kind of hope. They need the light, any technology or anything, they will go for it. And it's not for commercial reasons. Sometimes they really need this new hope, and then this will give them the results. Sometimes just one more cycle will lead them. We know that each embryo transferred, after all, is a chance of getting a pregnancy. And if they just are convinced and want to go through a new technology, it might lead them to this pregnancy. But that doesn't mean that the technology itself is what helped them reach this technology.
Jessica, and I agree with you about the giving hope for these patients, because they've come to you drained when they have recurrent cycles of implantation failure. But going back to the whole issue of scratching, there was a recent debate published in Fertility Sterility about many myths or many procedures that we apply in our daily IVF practices, and one of them was scratching. It was combined with assisted hatching. It was combined with different protocols, and there was a kind of a discussion and debate where there was some kind of evidence against the scratching, against the efficiency of scratching or effectiveness of the scratching in increasing the pregnancy rate in patients with recurrent implantation failure.
Yes, actually, I precise that scratching itself can be, it's not recommended as a first-line treatment or in a first IVF because it higher the immunity. So any scratch or any thing that you do on the endometrium will end up by changing the immune system in this endometrium.
Mhm.
Okay, so according to the Cochrane, so I don't know if it's the most updated. I will try to review this paper from Fertility Sterility that you're talking about. But
I think so,
scratching
right.
is recommended in repetitive implantation failure after at least 2 failed transfers of good embryos, actually. So this is I will surely update and I will look at the
Okay.
paper you're talking about.
Okay.
Thank you, Reno.
You're welcome.
There is a question by Dr. Farah. She would like to go live to ask her question. So, Dr. Farah, if you can unmute your mic, then maybe you can ask your question. Go ahead, Dr. Farah. Dr. Farah Farasha. Dr. Farah, can you unmute your mic? I'm not sure if we have technical problem with Dr. Farah. Dr. Farah, are you listening to us? Can you unmute your mic? Okay. I don't know what technical issue with Dr. Farah. Anyway, can I ask question myself now? It is about the concordance, Dr. Navarro, between the PGT-A that we do, the biopsies we do, and with the media we are analyzing. I mean, still it is far away from real reality. We're talking about the highest numbers like 88, 87%. Still, we're missing good number. What do you think? And we don't have really up till now a clinical evidence yet. I mean, we're talking about lab concordance. We don't know what happens in reality. Let's talk reality. Do you have any data to present or to share?
Yeah. So regarding the concordance, we at the moment it's in this study around 80%. Some of the studies on average, some of the groups on average have 86 more or less. Our experience in the daily life is that if the clinic is working properly, some of the batches were having more than 90%. But we know that it's gonna never be 100% because what we see in the media is not just the same that we have in the trophectoderm biopsy, because there is a small percentage of mosaicism. So our goal was, I mean, is still to try to increase the concordance up, let's say up to 90% would be the maximum in our opinion, because we know that there is going to be these differences between media and trophectoderm, because the DNA that is in the media comes from both parts, so it will never be the same. Regarding, we have already started with clinics. The study, we understand that the centers that enter in a study are very happy to do it, but at the same time, the transfers are not based in the result of the media. So in some cases we knew, because they sometimes were sharing with us their feelings. In some cases they didn't follow the protocol so well. But now that we have started with clinics, the validations are very good. The concordances are up to 90 in almost all of the cases. And with the clinical outcome data we have so far, the data is not so big because we are still waiting for all the clinics to share all the transfers, but it doesn't seem that the transfer based on the media has a lower rates than the PGT-A rates. So we are careful with that, but we think that the results of the media are going to be more representative of the whole embryo, and it's going to help us for the clinical outcome. But we cannot, at the moment, we have some data, but is not enough to be published. So we will wait until the end of the study that we think is going to be by next year, and we will show all of those results.
Thank you very much, Louis. We have one more question here coming from Dr. Rula Halabi. What do you think about using artificial intelligence with PGT-A?
I mean, some companies and even us, we are doing it. So it's quite good, because if you add to the algorithms that we are using for the diagnosis, what really you have at the end, that is the clinical outcome, the healthy baby at home. If you include that, you are improving it. So it's kind of a loop, and as much information you have to the diagnose, the better it's going to be, especially in some cases regarding, let's say, segmentals or mosaicism, all those hot topics at the moment. If we add all the information we have, at the end it's going to be better. And all of them, we are all doing the same. It's a reality, actually.
Thank you, Louis. Actually, it is an excellent meeting with, very nice information coming from all presenters, Dr. Rina, Dr. Joseph, Jessica, and Dr. Louise Navarro. We will be concluding with words from Dr. George Abitayeh. It was really fruitful. Many thanks for our presenters, for our audience, for the president, Dr. George, and the board members of the Lebanese Society, Fertility Society. And many thanks for iGenomics for supporting this event. Dr. George, the floor is yours.
Thank you, thank you. I want to thank all the attendees to be with us tonight. It was really an excellent webinar, one of our best webinar in this season. I want to thank our speakers, Dr. Ghaziri, thank you to be with us, Dr. Azoury with S, Jessica and Joseph, thank you very much. And doctors, we are happy with you this tonight. Dr. Aref, it was really perfect for us, this meeting. You were the chairman, and it was really excellent. Thank you for all your efforts, and I hope it will continue for the next years.
Sure.
Big thanks also to iGenomics and its team who help us make this webinar happen. Thanks for Sciences Pro for all its technical support, and for Carla. I hope to see you soon in our next webinar. It will be next month. And thank you again to be with us tonight, and have a good evening. Thank you very much. All of you.
Thank you.
Thank you.
Thank you, Dr. Aref. Thank you.
Good night. Thank you very much.
Thank
Thank you, Carla. Thank you, everyone. Thank you, professors. Thank you. Good night.